what do we learn now? Because we're making a turn here with AD, but we've already made this turn with other diseases, right? And everybody's been talking about psoriasis. Does psoriasis have anything to teach us about this shift from topical to injectable and paradigm shifts in the way you think about this disease?
Yeah, psoriasis does, in several ways. One is that, as Jeff pointed out earlier, we controlled the psoriasis drugs much more tightly when they first became available than we do now, because we've seen that, use seems to be pretty appropriate, And one of the things that we've learned, and we learn this all the time about new drugs, but it takes a little while, is who's prescribing them. Is it somebody who really is on top of how these drugs are used, has enough patients to know that? We find that almost always psoriasis drugs, when it's a biologic, is being prescribed by a dermatologist or occasionally by a rheumatologist, because the patient's primary presentation was psoriatic arthritis. And so for most of those patients then, now it's just a matter of, well, which psoriasis drug do we tell people to use first, because we've got a contract about it, but it's not really an argument about using psoriasis drugs. The other thing we've learned is that it's really hard to get the guidelines to keep up with practice. And so, for example, the dermatology guidelines for psoriasis usually say that patients should go through UV therapy unless there's some contraindication, like it's on the palms and soles and a couple other things like that. We almost never see UV therapy being used much anymore, because a lot of patients really don't like it. It's hard to get to the doctor's office. People don't want to have giant light boxes in their homes, which they have to pay some portion of for anyway, right? So there's a lot more movement towards biologics. So, so the clinical practice has moved more towards biologics, and the guideline hasn't quite caught up. And that's another important thing to know, is that we really do need to see guidelines get caught up. But generally, the most important thing has been that we learned that appropriateness of prescribing is happening, it's the right kind of prescribers, and the drugs don't need the kind of tight control we started with. And that's probably how this is going to go. But this is our version of what the Europeans call managed market entry, which is you start out with a very circumscribed kind of group of providers and patients and circumstances in which something can be used. And as we all learn what happens, we can expand that. And one way you expand that is by loosening up on the criteria and not getting so excited about it as it goes along. And that helps the payers, because we really do go into this without knowing how many patients are going to be seeking this therapy. Because on the one hand, we have, our own data, which we think is rather flawed in this area. We don't know that we know all the patients. And on the other hand, we've got, investment houses, saying that, they're pumping up the stock of the guys that are producing it, because they say, well, this is really going to be great. And the companies are sort of cringing, because on the one hand, they love it that the investors think it's great. And on the other hand, they know it's setting expectations that can't be met.
So do you anticipate, as things go forward, I don't know this, have the psoriasis drugs moved out from the specialty pharmacies, or are they still there?
Many of the psoriasis drugs are still in specialty.
So they're still controlled, at least in part, by
the biologics.
By the specialty pharmacies. So it's likely that these new drugs will further.
Well, they're not limited distribution drugs, though. So
no.
They do, and that's probably the nuanced difference. Is limited distribution drugs will go through specialty, non-limited distribution like the MS and RA and psoriasis drugs. A lot of those will go through retail.
Okay, but specialty pharmacies are going to be playing a large part in the foreseeable
with these, I
future
would
for
initially
this.
for sure. Yeah.
So, Jonathan, what's been your experience with regard to the level of support that you get as a clinician from the specialty pharmacies?
Yeah, for atopic dermatitis, hasn't been a huge issue so far. Because we haven't had these biologics.
But now you do.
Well, now we do, and so I think we're going to need that support, unquestionably.
But you have had other
Certainly,
diseases.
yeah.
Psoriasis again. We keep coming back to that.
Right. It's really been
what's
psoriasis.
the interaction with the clinicians and the specialty pharmacists?
It's really been psoriasis at the forefront, and then more recently hidradenitis suppurativa as well, with Humira being approved for that. But it's been, I think, overall good. I think we need to have dialogue, and we need the support in terms of the education. And this was something that you mentioned earlier. Education is so important on disease state for patients, but for providers as well, proper usage, who the appropriate patients are, and how to navigate whatever restrictions there will be.
And then we get the payers in this mix yet again. And how do they work with the specialty pharmacies to manage patients and manage costs at the same time?
I think specialty pharmacies bring a large value to how we manage patients.
Okay.
just like every plan's not great, you know, there are variations in specialty pharmacies. So, you know, what we try to avoid is the emphasis on like auto refills and things like that. And we really want to have a discussion around managing the patient and holistically. So, you know, that's you brought this up earlier. It's, you know, what are we doing with the with the depression and the sleep and other things, and so are these patients, and how does that fit in with our care management programs?
Okay.
So it really is data and integration, but it's aligning incentives. So, you know, a lot of times, you know, everybody in this room has different incentives, and unless those are aligned, then we're going to have problems. So if it really is about driving drug out of the specialty pharmacy, that's probably different than what we're trying to accomplish.
But you know what it sounds like to me? You're talking about specialty pharmacies. You're talking about specialty pharmacies. You're talking about specialty pharmacies. And you're sitting here right in the center. And we talk about stakeholders all getting together and managing all of this. Why am I hearing in the back of my brain, it's all going to come down to you, a specialty pharmacy?
We touch the patient, right? So we have wonderful manufacturers that bring amazing technologies to the forefront. We have prescribers who are prescribing those drugs. We have the payers. But
Is that why they call you diploma and diplomat?
Diplomat.
Yeah.
But we are the ones who are ultimately touching those patients. And quite often we're the ones preparing the case for appropriate utilization.
Well, that's what I mean.
Yeah, and that's the issue is, you know, most payers, PBMs, health plans, have their own pharmacy and therapeutics committee. They're the ones setting the utilization management criteria, and these are the ones that are implementing it on the patient side. So that's why that communication has to be.
Right,
Yeah.
but you're communicating with docs.
Doctors,
You're communicating with payers. You're communicating with patients. I mean, it seems to me that you're right there. You are that stakeholder hub.
which makes it very, very exciting when we start thinking about patient-reported outcomes, right? Particularly, you know, when we talk about atopic dermatitis. How can we get this real-world information? We can do this through specialty pharmacies.
So are we all going to vote to let her make all the decisions here, and we'll just sit back and the country is run by Cheryl?
If she takes the risk, yeah.
Why not?
But, you know, there is, you know, you talk about the right patient, right drug, right time, making sure that we're not auto-refilling medications. You know, one of the things that we do is call our patients. And generally, patients get a 1-month supply, so on or about 7 days before, we're calling them. Many times it's in this call that we discover, you know, overutilization of drug therapy, underutilization, maybe underutilization because of financial issues. Maybe if they're supposed to get an injection every other week, well, we ask them, we take an inventory check. How many do you have? Oh, well, I really can't afford it, so I'm stretching it. So then we really begin to get involved. We work with the manufacturers for copay assistance, or if we can't go there for government payers, we work with 501c3 organizations. So it is, I believe, the specialty pharmacy folks on the forefront. It's working with the payers on utilization management to make sure that that's the right patient, it's the right drug, and it's timed appropriately, and that we're helping that patient through any financial barriers to get that patient on drug therapy. And then again, it's the specialty pharmacy who, over time, is creating that supportive environment to help patients stay compliant with their therapy.
So do we all agree with her? Is this what they're doing? Are they doing it well?
Cheryl's company does. You know,
Independent specialty pharmacy.
yeah, you know, end of the day though, again, payers can't give up the control of their criteria and the decision making. It's their money.
Okay.
So, but we understand that specialty pharmacies can bring value to how we manage patients.